Thank you everyone for attending today. We're going to go ahead and get started with Pat Doyle.
Thanks, Daniel. Welcome, Vizient members. My name is Pat Doyle. I'm Executive Vice President, Business Development, Chief Development Officer for Signet Health. Signet is the strategic business partner with Vizient for behavioral health services. Signet is a 22-year-old family-owned company by the Jerry Browder family, owned by Jerry Browder family in the Dallas, Texas area. And in January of this past year, Signet acquired Diamond Healthcare, another large behavioral health management company. Together, we service hospitals in over 30 states. Signet also provides acute rehabilitation management services. What we have seen with the combination is 1 + 1 really does equal 3 between the two companies. Today, we're going to touch on how Vizient members are really going to rise up, as was discussed on a recent Vizient webinar, to try to address behavioral health needs due to the COVID-19 pandemic. We will touch on the needs of seniors, child adolescents, and then Joy Figarski, our President and Chief Operating Officer, will talk about the future trends in behavioral health care and what we need to do going forward to adapt. We'll conclude the discussion touching base on what Signet is already doing with other Vizient members across the United States for behavioral health strategies. We'll have a short question and answer session where the questions are simply read. You will not be identified where the questions came from. And at this point, I'm going to turn this over to Melissa Lehman, where she will talk about the pressing need for behavioral health care in seniors, how it's been impacted by COVID-19. And once again, members, thanks for attending today. Melissa?
Thank you, Pat. Good afternoon, everyone. First, I want to say thanks to each of you for taking time out of your busy schedules to join us today. Each of you have lots to do and many options, and we're honored to have you with us. I'm Melissa Lehman. I work in corporate clinical services with Signet Health, and today our presentation begins with the effect of COVID-19 upon the seniors that are in our country. Next slide. So on February 11th in 2020, the World Health Organization announced an official name for the disease that caused the 2019 novel coronavirus outbreak. And as all of us know, that was dubbed the coronavirus disease 2019, which has been abbreviated as COVID-19 and frequently referred to today as COVID. So the biopsychosocial toll on older Americans is significant, and each one has a unique story of their own. So as we begin our discussion, let's take a look at one story. This is the story of Polly. Polly is a 78-year-old female who had her hip replaced in February of 2020. And following 6 days in an inpatient stay, she was admitted to a nursing home-based rehab program at the onset of the COVID pandemic. Polly's husband, David, couldn't visit her during her convalescence in the home where she was receiving rehab, and he contracted COVID. So while she's there, he is admitted to the hospital 3 days following his diagnosis because his breathing became labored. And then he was later placed on a ventilator, and he died within 2 weeks of his diagnosis of COVID. So Polly wasn't able to be with David when he passed because of her health issues and the hospital's no visitor rule. And the rules are appropriate to protect staff and others from unknown exposure to COVID and save lives. There are consequences for policies like this, though. David died during that time frame with no family there, and Polly wasn't able to participate either with the planning of his funeral or implementing his funeral. They had no children, and the immediate family were not in the area of the country where they lived. So Polly spent many anxious hours regretting that David was alone when he died and that his funeral was not attended by family and friends. A few months later, she's experiencing prolonged grief and major depression. She did reach out for care at her local hospital, but no inpatient services were being offered. So she ended up with an inpatient admission after taking all of her medication to try to end her life. And then she did reach out for care again, and the services were offered virtually, and she had little or no understanding of computer technology and had no smartphone or internet provider service in her home. So as we are discussing all of the novel practices and interventions that we might be looking to do, certainly we want to look at how do we serve this type of population. So next slide. So let's look at some statistics for COVID-19 cases in the US as of March 24th, 2021. So looking at the table, compared with 5 to 17-year-olds, the rate of death is 45 times higher in 30 to 39-year-olds and 79 times higher for those who are 85 and older. And with 18 to 29-year-olds, the comparison for hospitalization is 8 times higher in those 75 to 84-year-olds. So the older population is certainly experiencing a huge amount of the burden of disease with COVID. Next slide. So let's look at loss and also interconnectedness. So our seniors are certainly having a loss of social support and experiencing social isolation, as many of us did early on in the pandemic. And then there's stress regarding other family members losing their jobs and having a lot of life changes themselves, children in the home being educated. Church and civic groups are suspended. Our seniors are not able to travel. And then they're experiencing death of family members and friends that are in their same age demographic. Grief is always hard, but with COVID restrictions on visitation, they're very difficult. Patients can't grieve together. There are no hugs. They're not able to hold their dying loved one's hand or just grieve together. No formal funerals were occurring. And these losses definitely affect the psychological sense of letting go, and that grief extends for a long time period. So our interconnectedness certainly helped us to get where we are with the COVID pandemic. That's why we're having to socially isolate. The silver lining is that this same interconnectedness also provides the foundation to identify and correct failures in mental health care through dissemination of research and best practices that enhance sustainable, equitable mental health care services for our seniors. Next slide. So anxiety and depression certainly occur in senior patients somewhat even before COVID, but COVID has certainly increased the number of people who are experiencing mental illness. Anxiety and depression are common within the elderly population with high physical risk of COVID infection, severe illness, hospitalization, and death. Those who already had pre-COVID symptoms of mental illness may experience an increase in their symptoms. So limitation on mental health care, as in Polly's case, can be associated with closures of outpatient services, moves to telehealth services that seniors are finding difficult to navigate. And the suicide rate among the elderly are at predictable levels. On a positive note, several studies do indicate that older people have higher levels of emotional regulation than those in younger age groups. And this resilience can help them cope better during a crisis than some of our younger individuals. Symptoms that our seniors may be experiencing are sleep disturbances, dietary intake abnormalities, an increase in alcohol and other substance use, worsening of chronic healthcare conditions like blood sugar, abnormalities, shortness of breath, high blood pressure, and pain that's associated with arthritis, just to name a few. They also experience those increased feelings of helplessness and hopelessness, and have the anxiety and fear of loss that's related to friends and family contracting COVID-19. Another disturbing aspect of coronavirus disease is the disproportionate harm that's caused to historically marginalized groups. So our Black, Hispanic, and Asian people have substantially higher rates of infection, hospitalization, and death compared with white individuals. So this is certainly occurring in our senior population as well. Next slide. So some interventions that are recommended for our seniors is certainly exercise and staying active. Research demonstrates exercise is good for seniors' physical and mental health, and even in small amounts can improve mood, relieve stress, and improve overall health and well-being. According to the CDC, 4 of 5 most extensive health conditions older adults face can actually be prevented or managed with physical activity, but only about 35% of adults over 65 are physically active. So this is one area that health professionals can certainly advocate for seniors. And even those with immobility can remain active with chair exercise. Research has also consistently shown that the Mediterranean diet is effective in reducing the risk of cardiovascular disease and overall mortality. The foundation of meal planning under the Mediterranean diet is fruits, vegetables, herbs, spices, olive oil, whole grains, and legumes. Fish and seafood can be taken twice a week, poultry, eggs, milk, and cheese daily. And wine is used as a medicine, and water to drink. Meats and sweets less often, and it's widely promoted for seniors to decrease the risk of that heart disease, depression, and dementia. Some vitamins are great also to supplement during COVID. Vitamin B can provide immune suppressants, and it can be found in fortified cereals or in a multivitamin. Vitamin C is provided through supplements of 500 milligrams daily or in citrus fruits and vegetables. Zinc also helps symptoms, nasal congestion, nasal drainage, sore throat, and cough all resolve sooner if you're taking zinc. And then research studies with vitamin D have shown higher serum levels of D show better outcomes from COVID. Other areas to encourage seniors is to keep their minds occupied through indoor activities. So doing a tour of a national zoo that's a virtual, and museums can be helpful. And children and grandchildren can help seniors set those virtual processes up. Seniors should also definitely take their vaccinations. They're in that high risk category, so strong advocacy for that is needed. Next slide. So let's look at some of the mental health responses in our country. The CARES Act allowed providers to place people over paperwork. The Substance Abuse and Mental Health Services, or SAMHSA, received $425 million under the CARES Act. And that money is earmarked to address mental health and substance use disorder needs as a result of COVID. And entities that are receiving funding are community behavioral health centers, and grant funding supports substance abuse programming and programming for the homeless population. Waived items included requirements that physicians or other healthcare providers hold licenses in the state that they provide services. So providers don't have to go through the waiting periods to receive a license in a different state. And many states have had swells of COVID and need and have been served by professionals out of state. Audio only services occurred through the 1135 waiver. On April 30th, 2020, the new ruling permitted audio only telephone care for multiple psychiatric codes. Sanctions under Section 188.17 regarding limitations on physician referral were lifted. That certainly became helpful. So as psychiatric providers rise up to answer needs of no internet service and low levels of technology skills to take advantage of telepsychiatry services, our seniors will benefit. Creativity and ingenuity are required now more than ever from leaders and frontline mental health professionals. Next slide. So learning to cope with the new normal following the pandemic is the work yet to accomplish. Following the surge in medical care required for COVID-19 is a predicted rise in mental health care needs. And that means all of us have to put our best effort into rising up to meet these challenges. I want to extend a warm introduction for our next speaker. Karen Vergano is the Senior Vice President of Clinical Services with Signet Health. And Karen brings many years of behavioral health leadership from clinical and nursing education sectors. So let's welcome Karen.
Thank you, Melissa. We recognize how COVID has changed our lives, no matter what the age. It is important to recognize that prior to COVID, depression and suicide in the older adult was always a problem. Based on this slide, you can see that the CDC provided some statistics. 1 to 5% of the general elder population have suffered from depression. 13.5% of elderly who require home health care have suffered from depression, as well as 11.5% in older adult patients that are hospitalized. Also note, 20 to 50% of individuals with common medical illnesses will develop depression. The older adult is going through the life stage of ego integrity versus despair, which can oftentimes lead to feelings of sadness and despair, which can, without treatment or ability to work through that issue, could lead to some depression. Next slide, please. It is important to recognize that older adults' attitude about depression is often associated with social stigma. Based on those attitudes, such as described in this slide, diagnosis and treatment for the depression in early stages does not often occur, with attitudes for mental health, including things such as 68% know little or almost nothing about depression. Only 38% of the older adult believe that depression is just a health problem. If suffering from depression, most older adults are more likely than any other group to handle it themselves. Only 42% of those people would seek health care. Next slide. This continues to show some older adult attitudes towards depression. Again, 58% believe it's normal to get depressed as one grows older. I want to emphasize that elder people are reluctant to talk about depression, and they often isolate themselves. Next slide. Unfortunately, untreated depression can lead to suicide. This slide, based on data from 2017, shows a suicide rate based on age and sex. With the COVID pandemic and growing social and economical concerns in our country, one can expect to see a rise in the near future in both depression and suicide. Next slide. Understanding and accepting the social dilemma related to the rise of depression and suicide in the older adult is absolutely necessary by developing interventions and treatments that Melissa identified. We need to place those treatments and interventions at the forefront in our healthcare systems. Thank you for allowing me this opportunity. And with that, I pass on to Tammy, who will talk with you about adolescents and children during the COVID.
Good afternoon. Thank you for spending some time with us this afternoon. My name is Tammy Thien, and I'm going to talk to you a few minutes about the effect that COVID-19 has had on our children and adolescents. We knew early last spring as behavioral health experts that shutting down our schools and the lack of contact with friends for our children and adolescents, the loss of milestones like birthdays, graduations, the cancellation of sporting events, all of those important events for teenagers and adolescents, that we were going to have some problems. Now the numbers are coming in, and in some ways they're worse, I think, than experts that had feared. Experts are calling this a pandemic among a pandemic from a pandemic. We knew that that COVID-19 had affected adults physically, but emotionally, teenagers and adolescents have been hit just as hard, and the long-term effects are not going away anytime soon. For this pandemic, we're not going to be able to take a vaccine and make it go away. It's here to stay for a while. Next slide. Pre-pandemic, 1 in 3 adolescents met criteria for an anxiety disorder by the age of 18. And prior to COVID-19, as many as 1 in 5 children had a diagnosis of a mental health disorder. You know, the teenage years are a time of changes, peer pressure, confusing feelings. It's a time when the teenagers are going through puberty. There's a lot of hormonal changes. So it can be very difficult to be a teenager with all the pressures. And then you add on a national pandemic, and it has caused a lot of trauma to teenagers that we're going to see, you know, a lot of problems that our children and teens are going to need some help to overcome. Next slide, please. Now we're going to talk some about ED visits related to mental health. Heightened stress, school closures, loss of income, and social isolation resulting from the pandemic have increased the risk for child abuse and neglect. Official reporting of child abuse and neglect actually started declining 20 to 70% in some states since the beginning of COVID-19, attributed to the decrease in contact with mandated reporters such as education staff, child care workers. So the first graph, you can see that actually the ED visits declined to almost 0 in the beginning of the pandemic. But then when the pediatric visits were pulled out of the mental health related visits, you can see that there was a steady increase from 2000. You can see the difference between 2019 and 20, what a steady increase that there was if you look on the second graph. And I want to share with you some information that I just read this morning that I found very alarming in a study by a nonprofit investigators. They combed through a database of 32 billion US health insurance claims, focusing on 2 billion or so 2019 to 2020 files from pediatric age groups. And some of the numbers are startling. This is the number that was so startling to me. there was a 334% spike in intentional self-harm behaviors among 13 to 18-year-olds in August of 2020 compared to the same month the year before. That was in the Northeast region of the United States. That was just startling to me, that big at 334% spike. So that was definitely attributed to the increase in the ED visits. Next slide, please. And then we broke it down into age groups. The 0 to 4 years of age groups, you can see there were some spikes in weeks, but not as steady as an increase as the 5 to 11 and the 12 to 17. 5 to 11, there was a 24% increase from 2019 to 2020. And then the 12 to 17, there was a 33% increase in ED related visits to mental health. Next slide. ED visits related to child abuse. We would expect, because of all the increased stress of people losing their jobs, their income, being isolated at home, that child abuse would be up, that domestic abuse would be increased. But after the president actually claimed a national emergency, ED visits related to child abuse, next slide please, actually went down to almost zero in the coming weeks after he declared the national emergency. Next slide. But then when they pulled out the visits that were visits ending up confirmed or suspected abuse that actually ended up in being hospitalized, you can see how much they had increased. So by the time these kids actually made it to the hospital for their injuries, they were severe enough that they needed hospitalized. Next slide. So there definitely has been an increase in suicide. Last summer, the CDC reported that 1 in 4 adults had contemplated suicide in the previous month. So we won't have the official numbers for suicide until about 2022, for 2020, but just the numbers that we've got coming in from individual states, I mean, they're alarming. Just for instance, Clark County School District that is in Nevada. During a 9-month period when their school was closed, they had 18 suicides during that 9-month period. That is up 50% from from 9 months before that. The youngest child that took his life was 9 years old. A 9-year-old boy at home in isolation took his own life. He thought he had nowhere else to turn but to take his own life, a 9-year-old. And there's more stories out there as kids as young as that, but that's just one example. Many more states, Pima County in Nevada, no, I'm sorry, I know where Pima County is, in Arizona, they report a 76% increase in suicides. Elementary schools all over the United States are bringing in pet therapy dogs because their young children, elementary school age children, they have increased anxiety. And all the hospitals across the states are reporting increased suicide attempts that are coming into the emergency rooms. Next slide. Loss of a parent. or grandparent. As of February 2021, an estimated 40,000 children had lost at least one parent due to COVID-19. Those children most of those children were not able to say goodbye to their parents. They weren't able to have the same support, their extended family around them to support them with the grieving process. Those children, we know that grieving can be a lifelong process, but to lose a parent during a national pandemic, those children are going to need specialized bereavement, counseling, support for a long time. It's just, we don't know what kind of effects that losing a parent during a national pandemic and the grieving process, what kind of long-term effects that this is going to have. Next slide, please. So there are several aspects of the pandemic that we expect may have some long-term effects for children and adolescents. First, the academics. Children have been pulled away from their normal routines. Learning at home. Some children do great learning at home on the computer, but then there's the children with special needs that need that routine day after day. So pulling a child out of their routine, away from their friends, we expect to see some downfall of learning down the road from that. Then exposures from having family members sick. Some children have been sick. Exposures to death, exposures to possible violence at home. They may have been victims of violence themselves. And then losses of loved ones, losses of expected milestones that they've missed. All of these losses have been very traumatic for some of our children. Next, please. Lack of resources. There's a serious shortage of mental health resources, of health providers. And we've known this for a long time, but actually COVID-19 has really shined a light on this problem. A lot of our resources for children mental health services are delivered in silos with little coordination with other services such as social services, other medical services, educational services. And then a lot of the states don't have that population approach to promote, prevent, identify, and treat children's mental health. So, so hopefully after this pandemic, we'll know better and we'll do better. We'll learn from this. Next, please. So what is the way forward? We know that we have to have resources that support young people, their families, and schools. We have to provide culturally appropriate support programming and resources that meet the community needs. And there has to be fair access to services to families from all racial and ethnic minority groups. And telehealth. Telehealth holds it really holds a promising future for our children out there in those rural, low income, high risk groups and community. But it only goes so far if we don't have providers, to back it. And we know that it only goes so far if we don't have the technology behind it. We know that we still need the Wi-Fi and, and those areas too. So we have we have a ways to go there, but it holds a lot of promise in those areas. And then the Medicaid expansion program. As members, if you've been thinking that, this might be the right time to start a program in your area for behavioral health, this might be the right time with the Medicaid expansion program. And Signet Health, we invite you to use us as one of your resources. We would be happy to answer any questions that you may have as the behavioral health experts. We would be happy and honored to help manage your behavioral health program. Next slide, please. But we do know that our children are in crisis, and these children are going to need interventions that can help them with their grief and ways that can prevent their mental health from becoming more severe and having more consequences down the road. Like I said before, there's going to be challenges that could emerge that we're not sure about because we don't know the impact of these children experiencing all this loss and having all this trauma during a national crisis. But we have to be prepared to respond with flexibility and compassionate programming. Now I'm going to turn it over to my colleague, Pat Scalfari, for the last few minutes. Thank you for your time.
Thank you, Tammy. My name is Pat Scalfari, and I am the Vice President of Clinical Services for Signet Healthcare. Just as we close Tammy's presentation, I wanted to invite everybody to look at all the things that we need to do to support our children's mental health. At Signet Health, we had the honor and privilege to work with a very proud, upcoming young man who was entering his senior year of high school. He was a great student, straight A student, no mental health issues. And then his school got closed. He had a really hard time dealing with this. At the same time, he lost his job. It was his first job. He was saving money for his own automobile. His mother was very involved in his upbringing. She was a single mom, and in fact, she was a healthcare provider. At work one day, she tried to text and call him many times. He didn't answer. So she sent the local police to do a wellness check. When they got there, he was actually near death. He had sustained self-inflicted bilateral wrist lacerations. He was treated in the emergency room. He actually went to the operating room for repair and then was on our behavioral health unit. And as we worked with her, she really admitted that many of these things that we see on this poster, she had noticed what were going on with her son for quite a while, but she really wasn't in tune to it. So we have the opportunity to provide great care to our youth at our facilities, and the need for this will be ongoing, not only into 22 and beyond. I would like to introduce our President and Chief Operating Officer, Joy Vergano, next to introduce our next segment. Thank you.
Good afternoon. First of all, I again also want to thank all the members who are participating in this. And we're going to talk about behavioral health into the future. Next slide, please. You know, there are many post-COVID challenges. Working with the member hospitals that you all do, you know them, you live those every day. But to name a few of the behavioral health specific challenges, you know, we know that 40% of adults reported a significant behavioral health problem in a study that was done in June 2020. The prevalence of symptoms of specific anxiety disorders, depression, increased incredibly. Anxiety alone went up approximately 3 times from what was reported in 2019. We already talked about suicidal ideation and attempts with many of my colleagues. This is all being increased by the US behavioral health crisis, and it's fueling up to $140 billion in added spending and countless suffering. You know, Tammy talked about children. Just today, this morning, I read a quote from Children's Hospital of Colorado, and they were reporting a 90% increase in demand of behavioral health treatment now compared to what it was. And they said there's many weeks where their #1 emergency department visit is because of a suicide attempt. That is just staggering to even think about. There's many disruptions in care due to the pandemic. We're very well aware of that. Next slide, please. But let's get a little hopeful and talk about moving into the future. I think one of the really important things, and going back to talk about the members webinar that Vizient sponsored recently, and a lot of it was talking about rising up, I would encourage and challenge all of us, every member that's on the phone or other members that you work with in your organizations, to think and talk and make plans for how we can rise up as healthcare providers to do better. Number one, the conversation's happening. When you turn on the television and Oprah and Prince Harry are talking about pretty significant private mental health problems, that's a change for us in this country, and it's very positive. We really need to work to create a culture of support, really focus on whole person care. It's the right thing to do, but it's also the right thing financially, because we know that in a population that is seriously and persistently mentally ill, for those of your organizations, the member organizations that are in fact either dove in or dipping a toe into population health, we know that the biggest spend in that population is actually the medical spend. And so whole person care makes sense for all kinds of reasons. We've already touched on telehealth. There have been many changes in policy and payment, and changes in who can qualify and who can provide the services. Hopefully none of those dials get turned back again. There's an app now, it's incredible. It's called Brightside, and it's actually for consumers. And it is actually supposed to help manage your symptoms for anxiety and depression. There's been a 50% increase in new users from the early pandemic to now. That's great. We talked about policy changes. There's a lot happening, which is very exciting to me, working in the behavioral health field, which I care passionately about. One is two women wrote A Path Forward: Mental Health and the United States Pandemic Response. The two women are pretty incredible. One, Shirlane McCrae, is the First Lady of Washington, D.C., and Linda Rosenberg was a past president for the National Council on Behavioral Health. A lot of that was building on the Affordable Care Act and mental health parity and taking it further. Next slide, please. There's a lot of opportunities for all of us beyond healthcare providers and the members on this webinar. Employers, one study showed that 68% of employers plan to increase their emphasis on behavioral health within the next 2 years. So there was a defined period. That's fabulous. There's a real opportunity for us to use population health affecting mental health policy to aim to really promote healing and wellness broadly for vulnerable populations. Next slide, please. Transformation of the data sharing environment. Huge opportunity there. I was mental health commissioner at one point in the state of Arkansas working on behavioral health reform. And one of the biggest things, and this is happening in every state in the country, was talking about the data sharing environment, because it's really hard to say you're going to have whole person care if the systems can't talk to each other. But there's a lot happening. California, for example, has published guidelines to promote effective sharing of behavioral health data. That's just one example. Other states are working on their data infrastructures as part of healthcare reform and patient-centered health homes. CMS and a lot of those have requirements, in fact, for a lot of that. Really empowering consumers. Stigma seems to finally be moving in a direction that's different. We know that ages 26 and above, about 35% of that population is seeing some type of a behavioral health professional, while 18 to 25, very different generation, self-reported 60%. Next slide, please. There are huge technology opportunities. I'm just going to run through a few, but of course you can go in and research any of these. Virtual assistants. So there are chat bots. I didn't even know what a chat bot was when I started researching this, and emotion-based algorithms to provide psychological support directly to people. One is called Tess, and it's actually a mental health chat bot that provides coping strategies for people suffering with some kind of a behavioral health problem. There are digital consumer experience technologies. These are platforms that manage the patient relationship and monitor and exchange information between patients and caregivers, and then connect the patients to specific tools. One is called NeuroFlow, and it actually is a suite of tools that enables remote monitoring and behavioral health integration across continuums of care. There's all kinds of diagnostic support screening tools. One is called Unmind, and it's a workplace mental health platform that empowers organizations and employees to measurably change, whether it's their anxiety or how they're, feeling in another negative way. Next slide, please. Digital phenotyping. This is really customized treatment monitoring and clinical decisions for new biomarkers by wearable devices. One is called Abilify MySight, and it's actually a prescription of a tablet with an ingestible event marker sensor inside. I mean, it sounds real sci-fi, but these things are tools that are out there now. All kinds of neurological interventions. One is WVU Medicine, who I have to give a shout out. Our chief medical officer was the chief of psychiatry there. Not why I'm mentioning it, by the way. It's pretty cool. They have a clinical trial with deep brain stimulation for treatment-resistant opioid disorders. And we know that opioid disorders are extremely, extremely difficult to treat. Physical, augmented, and virtual reality. These are interventions with hyper-realistic environments. One is called a calm place. I mean, who couldn't use that sometimes at the end of a work week in healthcare through COVID? Next slide. So before I hand this over to Pat, I want to tell a very 2-minute story. And I think, to me, it really is enough reason for all of us to rise up and to be that voice in our organizations, that champion, that really challenges, encourages all of us to think about how we can do better in behavioral health. There's a young woman named Lauren at the very, very, very beginning of COVID, back when it was March, and it was first starting to spread in a lot of the states. She had a toddler at home, a wonderful young husband, and had given birth in a very well-respected medical facility. And she was running a fever. And that was back, if all of you members remember, when it was really hard to even get your hands on a COVID test, even as a provider. I mean, we even had some units that had to close for a while as we thought and really struggled with how could we all get our hands on COVID tests. Anyway, so they assumed she had COVID because of the symptoms and sent her home without a COVID test. And she wound up passing away within 24 hours. And it turned out she didn't have COVID. She had a uterine infection that could have been treated. The tie to mental health here is her young husband isolated. A lot of family was out of the country, and the few family that were here really couldn't have access to help him. And so here he was now with a toddler and a newborn, and a huge amount of financial burden aside from being heartbroken. And over the course of that next year, he really slid into a very deep depression and started experiencing pretty significant substance abuse problems that he had not ever had before. And he's alive. He wound up in one of our programs, and it was just a tragedy as we think back about how many lives have been touched in direct and indirect ways. So I'm going to turn it over to Pat now, but I guess, there is opportunity, and I think we all have a serious responsibility in healthcare to rise to the challenge. Thank you so much.
Thanks, Joy. Daniel, next slide. Next slide. So Signet, when we work with members, we really can help focus on looking at new programs that may be needed in the community. Could be geropsychiatry, as you heard briefly today, could be child adolescent services. It could be a crisis stabilization unit, medical detox, inpatient connected to chemical dependency intensive outpatient program. Could be a variety of things, but we do have a lot of experience, decades, of trying to assess what's needed in the community and what can make sense. And we also have a lot of experience coast to coast working with existing programs to try to enhance the performance of the program. The slide right before this showed a building. Signet's third area that we're pretty active in is working with hospitals where there might be need of a new behavioral health pavilion or psychiatric hospital. We can help partner with the member, help finance this, and recommend something that's not only needed in community, but works financially for the member. So we're going to turn this over to question and answers. Once again, please contact us if there's any questions about Signet services. And on the question and answers, they'll be done confidentially. So please submit some to the panelists.
So we've got a few questions today that have been submitted. Got a question here. With freestanding psychiatric hospitals being built in a number of service areas, how can my inpatient psychiatric unit inside our hospital compete with these newer and larger facilities?
Okay, I'll address that one. We are seeing activity, and I'm sure some of the members are by different psychiatric hospital companies. And what Signet does, almost all of our 80 plus partnerships are with community med-surg hospitals. So we know how to partner with the community med-surg hospital, and we can put up a building where it's warranted that can make sense, not only provide you new and exciting space for behavioral health programs, but it could also free up space in the med-surg hospital, which many hospitals find that as a benefit. So if you think there's an interest in that kind of expansion, please contact me. Thanks, Daniel.
I also wanted to just pipe in with it. One of the things that we market when we work in partnership with a member is that when there's a pavilion or a unit within your hospital, but attached in some way to your med-surg system, it really behooves being able to give a complexity of medical care to a population, adult as well as gero for sure, that has often a complexity of medical issues that that just can't happen the same way in a freestanding psychiatric facility that's on its own. So thank you.
Next question. It's been difficult for us to recruit psychiatric providers during sometimes. How does Signet assist with provider recruitment?
I'll take that one if that's okay. Gosh, I get asked this every single time as president that I go out on a sales call with one of our sales development VPs, and it's a very fair question. I don't have a magic wand. I wish I did. I don't have a doctor bus. I also wish I had that. But what I can say is that we've never, ever missed opening a program because we couldn't get a provider. It's just, this is what we've been doing our whole lives for most of us. And again, not that I have some magic wand, but it's our livelihood and we have a lot riding on it. We wouldn't have member partners if we weren't able to recruit providers. It's hard. We always recommend having a multifaceted approach from day one and being very aggressive about it with all of our resources, but so we get it done.
Next question. Let's see. How have Signet programs at hospitals dealt with psychiatric inpatients that contracted COVID-19 while on the inpatient psychiatric unit?
Goodness, I'm going to start and then see if any of my clinical VP colleagues have anything they want to add, since they're all nurses and I just play one on television. Basically, we work really our job is to be seamless. So when we work with a member partner, our job is to be seamless. So there isn't one cookie cutter answer. We looked at best practices though, all over the country. One of the nice things that we do have is with having, 80 plus programs, in over 30 states, we're able to really study and look at what best practices are and then share that information with our member partner chief nursing officers and liaisons and chief medical officers and physician providers across the country. So, we've had everything from units that were double rooms going down to single rooms, putting all kinds of testing into place before admission. I'll let them add, but there really wasn't one cookie cutter because we want to fit in, we want to provide best practices, but we're there to work in partnership, not to tell you how you have to run your hospital. If Pat or Karen or Tammy, if you want to add anything.
Yeah, thanks, Joy. One of the creative things that we did in one of our facilities in Connecticut was we actually set up zones within the unit. And so we had color-coded zones with green, yellow, and red that designated the COVID patients, those under suspect, and the patients that didn't have COVID. We definitely had different staff working in the different areas, and we were able to keep servicing our patients.
I just wanted to add that we work directly with the hospital infection control department and developed guidelines. And those guidelines, we made the practice to follow those guidelines, and we shared it among all of our units under Signet Healthcare.
Last question here is telehealth therapy more difficult when working with children and adolescents, and is it effective?
I'm going to take a shot at that one. It's very effective. I say all the time when I meet with chief medical officers and CNOs and CEOs, I said it last week sitting with Pat, actually, we were with a system somewhere. To me, it's always going to be the quality of your provider and your staff and how that's interactions are managed, as opposed to the form of how it's done, whether it's face-to-face or telehealth. Telehealth can work really, really well with children. I find, to be honest, children are very accepting of change. I will say even on our geriatric units, though, where I was a little skeptical at first, it's worked really, really well. And again, it's come down to, and certainly with adults as well, but I'm saying I really, across all populations, and it really comes down to the quality of the provider, the equipment working, and the staff supporting it.
That is all of our questions. Thank you for attending today. And Pat, Doyle, did you have anything to close out?
No, once again, we really appreciate Vizient and Jenny Contreras helping us to sponsor this, and we look forward to talking with the members throughout the country.